Welcome to the International Workshop on COVID-19 Lessons to Inform Pandemic Influenza Response. We're on day 2 of the workshop on the supply chain cascade. And we're also in a breakout session. This is the breakout session 2 on financing and investment. We are glad you can join us. Pleasure. If you wish to join one of the other breakout sessions, please click on a button below corresponding to the correct number as listed on the agenda. Otherwise, enjoy the lively discussion here and feel free to post your questions. We're going to reserve 15 minutes at the end to take questions from the audience. So anyway, welcome. I'm Christopher Snyder. I teach in the Department of Economics at Dartmouth. It's a university located in the woods in the Northeast U.S. I serve on the National Academy of Science and Medicine study on the global coordination and financing to inform future influenza pandemic responses. And I'm going to, part of my task is to go and collect information from as many people as possible. And I'm just privileged to be moderating this discussion among some experts. And I'm going to be taking copious notes because we're going to be learning a lot here. So let me start off by asking our 3 speakers, and I'll introduce each speaker as I come to them and give just a word of background. So the first question I'll throw out there is just to ask we have a series of speakers who are kind of operating at different constituencies. So we have the WHO serving the world, UNICEF serving low-income countries worldwide, and then from the supply of sub-Saharan Africa. So we're starting broad and narrowing in. I'd like to ask each one of the panelists from your personal experience about the current COVID pandemic first, and then we'll talk about future pandemics. When can we expect, or should we even expect widespread vaccinations campaigns to be undertaken among your constituencies? When should we expect that to potentially be completed? Are there opportunities to accelerate that? And what could you recommend to help accelerate the rollout of vaccine and response? In a sense, what are the barriers that can be overcome? So I'm going to first start with Dr. Erin Sparrow. She's technical officer from the Vaccine Product and Delivery Research for the World Health Organization. And all of our speakers have incredible educational backgrounds. She has her PhD in public health from the University of New South Wales. So Erin?
Thank you. So I'll start by saying that although I work at WHO in the immunisation department, I'm not directly involved in the COVAX facility, but a lot of my colleagues are. But my expertise really has been in developing influenza vaccine production capacity in low and middle income countries for over a decade. And I think that there are some lessons to be learned there when we think about moving forward with expanding production capacity for vaccines for future preparedness. But coming back to your question, which is about, how I see vaccine rollout taking place, I think what we're going to see in 2021 is supply constraints. The COVAX facility has done pretty well. There's been 69 million doses as of today shipped out, and more doses will be coming. But it's a drop in the ocean. It's just not enough. And what we're seeing is some countries have already started vaccinating their younger populations, while other countries haven't even started with their healthcare workers and risk groups. And that's a concern because the people that are most at risk of dying are not getting the vaccine, whereas people that, would be more likely to have a mild infection in some countries are getting immunised. And I myself have been immunised, and I mean, that's because I'm in Switzerland, but if I was in any other country, that would be questionable when I would actually get the vaccine, and it probably would not be this year. So I think for the immediate future, we will be continuing to see supply constraints, and that's why the WHO is encouraging manufacturers to sign up to the COVAX facility, countries to participate in that COVAX facility to ensure that there is equitable distribution of COVID-19 vaccines on a global scale, not to just high-income countries, but all types of countries.
Thank you very much. So let's move over then to Nagwa Hasanin, the Senior Advisor for Health Supply Division in UNICEF. She's has her PhD in immunology from the University of Cairo. So again, talking about maybe if you have a perspective on if it's realistic even to think we're going to have a widespread vaccine campaign worldwide among your constituent countries, when we'd expect to see it, and what can be done to accelerate that, if any, financing or supply constraints.
Thank you very much. So maybe I would like to start with my background as a molecular biologist, and I was involved personally in vaccine manufacturing in my country as a low and middle income countries. I had the knowledge from that side on what are the hurdles and what are the obstacles, because I was part of that system. As part of my role with UNICEF supply division, our main role is securing pediatric vaccinations for the low and middle income countries, which is a different story when we compare to large-scale vaccination, platforms of adult vaccinations. This is something that we were never prepared for. And even for adulthood vaccination, for the childhood pediatric vaccination, we had obstacles in financing issues because country cannot pay for that vaccine. UNICEF is supplying more than 40% of the vaccines through Gavi and through several combined finance mechanisms. So still now the governments have competing priorities about supplying pediatric vaccination for the children. And then coming on top of that, the other competing priorities like other public health issues, malaria or HIV or other competing priorities. And when we have been faced by a pandemic at that large scale, two things we were not prepared. We were not prepared on the health system strengthening component. So we didn't have an infrastructure at the health system level to be able to secure that we have the tools to deliver this type of vaccination to a different population. The second is about the financing component. And the countries are struggling and standing in line behind others as they take the vaccines. Not only vaccines, we have seen that with the personal protective equipment. Until now, we have the diagnostics. So from where we are, it's not only about the vaccine, because we're talking about a vaccine preventable disease, but we're talking about the governance structure around pandemic response and preparedness, including finances, policy, national rollout plan, and this is very hard. And I think two things with what struck us that in the beginning if we have a seasonal influenza platform that was already established in these countries, we would be able to build upon it and secure and start to roll. But in our low and middle income countries, at least on our constituents, there is no national, UNICEF is supplying basically no seasonal influenza platform. It's around financing, community engagement, risk assessment. It's a little bit of complex down the stream. The second is actually around the accessibility of the vaccine in terms of the knowledge, the know-how, the IPR, the possibilities that you have local manufacturers of many of these medical countermeasures, that you can work with them to bring the building capacity and the human and resources up to that level to produce. We had trying, for example, for PPE to use garment industry manufacturers, that we can help the garment industry to move them and repurpose the plants into producing our PPE at a local scale. The same with diagnostics. How can we improve access to diagnostics? And vaccine is, of course, is the hardest of all, but I think if we have a possibility to have some sort of routine vaccination, stable, sustainable routine vaccination on continent and low and middle income countries, this will help us to bring them up to a different level of producing different vaccines, providing that we don't have the same situation like what we've seen with COVID, of course. This is what we don't want. We want to be prepared. Over.
Thank you very much. And so now we're going to turn to an even more local perspective. Tapiwa Mukwashi, the director of the supply chain of Village Reach. That's a NGO that looks for innovative systems to supply and deliver the last mile of health supplies and health systems to sub-Saharan Africa. And his educational background is a master's in shipping and transport from Netherlands Maritime University. So an OR expert. So again, I'll put the same question to you. Maybe you want to focus more on the supply logistics challenges.
Thanks, Chris, for that question. And I think, as you mentioned, the supply chain is a very complex issue. And one of the challenges that we face is that we have a very limited access to the supply chain. And this is why we need to work with partners, One thing I want to say is that there's been so much talk about making vaccines available, and so much planning around making vaccines available. There has been logistic effort through different mechanisms, for instance, through the COVAX facility, to deliver vaccines to a number of countries. The perspectives I'll share are derived from some of our experience where Village Reach works in Mozambique, in the DRC, in Malawi, and Liberia. All these countries have received some vaccines of some sort, either by direct bilateral donation or through the COVAX facility. The general narrative was the expectation that once vaccines became available, there would potentially be a stampede for vaccines. The vaccines would not be enough, and populations had to be segmented, starting off possibly with the older population, in a way that would bring equity in the deployment of the vaccines. But what we are finding is that when the vaccines have become available, there has been so much hesitancy amongst the populations to be vaccinated, which some of the early stage logistic implications is that we have a very high wastage rate. On the news, there's been all this talk about Malawi destroying over 20,000 vaccines because they had an expiry date. In Liberia, there is sustained planning and panic around the possibility of having over 30,000 vaccines expiring, with possibly a rate of 2,000 people getting vaccinated per day, which is just not enough to enable the utilization and optimal use of all the vaccines that are available. So I want to say, whereas there's so much planning on the supply side, increasing the capacity to manufacture, increasing the capacity to supply, there is also a need to manage the demand side, making sure that there is sustained enough investments to encourage people to take the vaccines, to assure them that it is safe, to combat all the misinformation that people are receiving around the vaccine. You asked Chris that when do we expect that the vaccination will end, if it is going to end, and if end means 90% of the population having been vaccinated, an optimist view would say they will end in 2024, but a more pragmatic view is around 2025, 2026. Understanding that we've got to balance supply constraints with vaccine hesitancy. So it's going to be a real slow process of deployment, engaging communities, in a way allowing the logistic capabilities to build up as the supply is also getting built up. So yes, 2025 it will be, and it's really a marathon. It's not a sprint. Thanks, Chris.
Can I just follow up with a question that occurs to me? I mean, one problem might be if you receive 20,000 doses, it's not even enough to come up with a wide-scale campaign. It seems like, in a sense, it has to be a more coordinated, wider scale up, and then people might start signing on. But is that, or do you see it more emerging as organically that it should start small and expand?
I think the thinking had been that 20,000 vaccines are a small number. And this had been informed by the national vaccine deployment plans that countries had prepared. They seem to suggest that the health workers would get the vaccines, the police force, the army would get the vaccines, and in number, they are way more than the 20,000. But the utilization rate amongst the health workers themselves is very low. There is very low uptake. Amongst the security forces, the uptake has also been very, very slow. And you will see that there is, can I say, cell phone-based techniques, sending out messages, encouraging people that the vaccine is safe. radio programs to generate more demand. These segmentation that had been done, that nurses first and other populations later, have been lifted. In Zimbabwe, anyone can walk into a clinic now, get vaccinated because the vaccines are there. But the clinics are not as full as you'd expect them to be. With the effect that in the press, there's talk about vaccine tourism, people jumping out from South Africa to come to get vaccinated in Zimbabwe because of the relative ease. But you'd wonder that if it is so easy to get vaccinated, you can walk into a clinic, any clinic, get vaccinated, then why are people not getting vaccinated? And we are staring at vaccines with a short shelf life. I think this is another question that hopefully we will deal with as to how manufacturers are giving a short shelf life to the vaccines, maybe because of the information they have, and hoping that they can revise the shelf life once the vaccines have been delivered, which presents a whole political challenge for governments, and many are unwilling to take on that as well.
Thank you. I never thought of that issue. I'm going to add that to the agenda of the study. I'm going to just go back in sort of reverse order to follow up with Nagwa about a point that you made. So the issue is, for future pandemics, you can either try to, in a sense, focus on possibly responding to a pandemic as a separate issue for flu, or you can try to build on the seasonal flu infrastructure. And that's a big question that my panel is struggling with. And that's one of the big questions. I just see there being kind of a risk that there's like zero rollout basically of seasonal flu in many of these countries that you're serving. And, it would be, obviously we want to build on that, but if it takes, say, 10 or 20 years to actually build that out, is that too risky? And we might have a pandemic that comes before that. So it seems like there's a trade-off there. I wonder what your thoughts are on, the balance there. If it's worth, should we just proceed on several fronts, you think, or should we put all our eggs in riding on the seasonal flu platform?
Definitely, totally agree. I think one of the lessons learned from the COVID currently is that we can't depend on either one platform of vaccine or one platform of delivery because we're not prepared for. If we're going to be hit with an outbreak of a mass scale, we need to be able to have tools to address the accessibility of the population. One of the thinking that we had prior is that if we had developed, because we never had an adult vaccination platform to deliver a vaccine except from the HPV for the human papillomavirus, maybe for the Hajj and Umrah, for the meningitis, for these travel things, maybe for yellow fever, very small and very localized and it's a control. But accessing population, especially population at risk, like if you want to access older population or populations that are on the front line, the accessibility of these populations is very hard. And we have struggled with hepatitis B vaccination for healthcare workers, for example. So seasonal flu was a logical platform. If we have the seasonal flu vaccination platform, we will be able to access population. But for other reasons, if we have the seasonal flu local manufacturing, we're going to have more sustainability on the demand side. If we're going to have people, if there is an ownership on the production of some of the vaccines that are being used in the country. And we had neither. So what we've seen from that perspective, two things. First, that we had new platforms for delivering vaccine, like RNA vaccines or other type of vaccine, new vaccines that will require different manufacturing. And I don't know if this will be able to produce in the low resources settings. The second is around how can we use other delivery system within the health system to be able to access the target cohorts that we need to access, and not only seasonal flu. And I think the key question is the preparedness plan. We can't do things in the middle of the outbreak. We need to be able to prepare and have more simulation exercises to be able to see if we can access these target cohort and if the system is capable of. Because it's not only the vaccine, it's the delivery devices and also the delivery diagnostics, if we need to do at one point screening prior or after, and then if we have to monitor adverse events following immunization, all of that is a comprehensive system. And I think what we're asking ourselves is that we need to have, of course, parallel system.
Thank you very much. So now let's turn to Erin Sparrow. I'm not sure if you want to follow up on any of those comments. The question I would throw out to you is we talked about the COVID epidemic, and hopefully that'll end. And, one would hope in 2 years, but it sounds like Tapiwa is saying no, vaccination is not going to be for many more than 4 or 5 years, which is somewhat realistic but depressing to me. So what about the future of, say, influenza or any kind of respiratory pathogen pandemic? What are your perspectives on kind of what the WHO or what the world needs to, the major investments we need to undertake?
So I will follow up with follow on from some of the ideas that Nagwa was talking about with influenza, seasonal influenza use or vaccine production and pandemic preparedness, because it's actually a project that I was involved in for more than a decade at WHO. In 2006, we launched the Global Action Plan for Influenza Vaccines, which had 3 pillars. The first pillar was about increasing the use of seasonal influenza vaccines to increase demand and also to address seasonal influenza. The second pillar was about increasing production capacity so that in the event of a pandemic, that seasonal influenza production capacity could be leveraged to make monovalent pandemic vaccines. And the third pillar was about promoting research and development for new, better, faster, more broadly immunogenic influenza vaccines. And the pillar that I was really heavily involved in was this increase in production capacity. And we were funded heavily by the US government, by HHS, BARDA, to help several developing countries build influenza vaccine production. And they started from scratch. Some of these manufacturers started with a green field, literally grass. They had to get pipes in, they had to get electricity, and they had to build the foundations. They had to construct a GMP-grade facility, establish a process, validate that process, do all their preclinical and clinical testing. Overall, the investment was about $1 billion over these 14 manufacturers that were in the program, a lot of local investment as well as international investment. And some of them were successful, some of them weren't. But what a lot of them are facing now is that they have a vaccine production facility and they've licensed their seasonal vaccine, but they're challenged by not having a market. And so they're finding that they cannot compete in terms of price with some of the big multinational vaccine manufacturers who can produce at economies of scale. What I've seen is that the influenza vaccine market is quite volatile for small influenza vaccine producers. And we've seen some producers come on the market only to be gone 2 years later. So I think what we need is, as Nagwa said, is multiple platforms. We need to have this seasonal influenza vaccine infrastructure in place that can be leveraged in the event of a pandemic. But we also need to have platform technologies that can be switched on, like, plug and play mRNA technologies that can basically download the genetic sequence and, a few weeks later, you've got your vaccine ready for clinical trials. So one thing that I also wanted to stress is that if in the event of an influenza pandemic, say in 5 years' time, we're hit with an influenza pandemic, there is going to be inequitable production of influenza vaccines. I think there's about 31 countries that have influenza vaccine production. And about 50% of those are actually low and middle income countries, which sounds great, but actually they only have production capacity for 20% of global production, yet they have over 80% of the population. So it's going to be a similar situation of high income countries producing the bulk of vaccines and low income countries not having enough production and relying on donations and facilities like COVAX or the Pandemic Influenza Preparedness Framework to supply the vaccine they need. So I think the lessons that we're going to learn from COVID need to be absolutely taken forward and taken into consideration to build a better, more equitable system for the future, because what we have isn't good enough. There's no question there.
Can I follow up with a question on that? In a sense, one could take two different lessons from, what we learned from COVID. One is that, we didn't get supplies to some of the low income countries and they have basically no vaccine. So, what's the antidote to that disease? One perspective is distributed manufacturing. Although, you've been involved in some of these things, it's a difficult process. This is the most complicated substance or product that you could possibly manufacture, and high tech thing, and it's to distribute that to low income countries without the industrial setup might be difficult. A different lesson to take from it is that really what we needed was just capacity, no matter where it was. So suppose it's in Switzerland. But if say Switzerland had some of the capacity that we're talking about to produce, say, 11 billion doses, the question is what time frame, say annual doses, then Switzerland is first in line, but Switzerland's a small country. They can vaccinate everybody in Switzerland with capacity like that. In say 3 days, you've hardly slowed down global supply. So, a different perspective would be, it doesn't necessarily have to be distributed. It's just the scale that we need.
Yeah. And actually what I really like is this idea of having hubs. There could be regional hubs, but that would have these sort of platform technologies like mRNA or something else that could be leveraged in the event of a pandemic and produce the amount of vaccine that the world needs very rapidly. But in order to establish those production facilities, what you need is global cooperation, a long-term vision to get there. Because it's going to take time to build those hubs, especially for mRNA, which is a new technology. IP barriers aside, I think there's a lot of know-how that's not really out there yet. And we were lucky enough that when we started the influenza vaccine technology transfer project, we were using technology that was 50 years old. No IP barriers. But secondly, we had a lot of ex-industry consultants that were happy to put up their hands and help these manufacturers along the way. So I think there's know-how is going to be a major barrier, and that's why long-term vision is going to be needed. And there's going to be a lot of funds needed initially, but continued funding, because those facilities, once they're built, they need to be sustained. They need to have a warm base where they're producing material routinely, so that they have the trained staff and the infrastructure ready to go when needed.
Thank you. So why don't we go to Tapiwa? Do you have any follow-up from those exchanges?
Absolutely, Chris. So Erin has mentioned some key learnings that we are seeing in the COVID environment, that it's important to scale up capacity and to scale it up very rapidly. But it takes a whole lot more to sustain that capacity. And there are also questions about whether we must sustain the capacity at its peak levels. Is it sustainable? Is it efficient? Is it effective? So from a logistic sense, you will see that some of the things that happened was a lot of manufacturers repurpose their productive capacity, say in the PPE. And now many manufacturers are finding themselves stuck with mountains of PPE that's not moving, that's not selling at the peak pricing that motivated them to go into that production line. So it will be very important to understand from this COVID outbreak what the steady state capacity really is, so that the global stakeholders, the global financiers, the local governments focus on financing the sustainability of a capacity that's suitable for purpose. Otherwise, if there's too much redundancy, there is excessive wastage as well, which will make people question about whether we are responding in the most appropriate way to future pandemics. So repurposing the capacity, avoiding inventing new capacity through the engagement of the private sector, making sure that we work on those legal constraints that limit the export of technology transfers. These are very important in making sure that we strengthen regional production facilities, country-level production facilities for countries with low populations may not be that effective. So regional level production facilities may justify an ability to, sustain production in geographies where the response can be quicker, where, vaccine nationalism can be neutralized in a way, and things like that. Thank you.
Can I just stick there? There's some questions coming in from the audience, and this is a kind of really specific question, but maybe you can just give a word or two response. It's basically this is a researcher at The Ohio State University is asking about the logistics like power supply. Do you see that as a big constraint in vaccine delivery system, and can that be overcome, and what investments are needed there? Maybe just a sentence or two on that.
Absolutely. At the volume at which vaccines have traditionally flowed into countries, power is an issue, but not that much of an issue. At the volume of vaccines that we were expecting with the COVID pandemic, which was possibly 10 times more the volume of vaccines that have traditionally been handled, there is certainly a concern that power is an issue. I know UNDP, other organizations have moved ahead of the wave, trying to use solar energy in Mozambique, in Zimbabwe, to try and sustain the availability of power in some remote facilities. But yes, at huge volumes, power is an issue. At smaller volumes, there are logistic measures that can be put in place to make sure that either in cooler boxes, vaccines can be made available to locations on a periodic basis. But yes, power is an issue.
Okay, thanks. Nagwa, do you have any, has Erin's comments or Tapiwa's comments spurred any thoughts? I have some other audience questions otherwise. But I'll let you.
Yeah, just one comment on the power thing. And I think we've seen that or anticipated that on the waste management component, because running the incinerators or the autoclave requires really a high energy, and we can obtain that from solar energy. But this is at the mass scale, as exactly as Tapiwa was saying. But because Africa did not really move to that massive scale, we're not prepared. But if we have enough vaccine and if we want to roll it, this is something that we don't have. And we have to on the other thing, on the sustainability, I think, which is just follow up on what Erin was mentioning. I think the value proposition is an important, because the sustainability of component supply versus demand and the involvement of the population in making the vaccine. I think this would be an important ownership and building up I don't think that we need to have manufacturing in every country, but at least we're going to have like a continent producer, big continent producer. One of the lessons learned that we had from the pandemic is when China was first hit, we didn't have access to anything, because most of our supply agreements were based for suppliers in China because of the price issue. They are really offering competitive pricing, and we have, as UNICEF Supply Division, we have all our base contracts for gloves, for PPE, for cold chain equipment, for bed nets, for all the massive products were for China. So we were hit and we had to catch up. And diversitizing the supplier base was important for those supplies, for diagnostics as well, building up on key universities where they are making in-house protocol for PCR or direct access for. This is really important, as well as for vaccine, that we have a hub there region that we can rely on. Over.
Do you just following up with you, you were talking about the priorities that the low-income countries you serve, they have such a large set of priorities. You're talking about seasonal flu, that's not being rolled out, probably because in part, maybe they don't see that as a big concern relative to some other life-threatening diseases. Do you see COVID as being, there's hesitancy, but in part, I think because, the disease prevalence isn't that high in some of these countries. Should we take it on faith that, COVID should be a priority over some of these other things and even pandemic flu? or maybe it's not an either or. It's a both and.
Yeah, I think was another inequity, which is the access to data, that we were not able to identify the epidemic trajectories, and everybody take a situation where this is not for us in Africa. It's not happening to us. It's happening to other people. So we are dying from malaria. We're dying from simple disease. Like we have a huge drop in our pediatric vaccination coverage because because with the stop and the lockdown, the mother could not take the child for getting the basic vaccination, like for polio, for measles. So we have measles outbreak, we have cholera outbreak, we had even Ebola in DRC. So it's just from the perspective of high income countries, the trajectory is very high. The average age of population is very high as well. So these are the high risk group. When we look to Africa, it's a young continent where it's completely different issues. Accessibility to antiretroviral for treatment of HIV was affected. So there was secondary impact that really impacted the life of people from other diseases. So we could not put them together. So when we talk about take the COVID vaccine to survive, say, but I'm dying from others with a huge number, and we can't have data to say that COVID is affecting. So again, it's ownership. It's that we can't do it either or. We have to do as our international community. We have to take the ownership, make sure that we have a wider governance structure for pandemic and outbreak, reviewing our national pandemic plans and ensuring that we can access the surveillance data, because we're depending on this event-based surveillance where we only, if you catch the cases, but there is no, it's a bigger picture of the preparedness. And I think influenza should fit within a bigger picture. And the hesitancy today is because we just send the vaccine and we're saying, now you need to take the vaccine. But if we have a plan about risk communication, community engagement, highlighting how can we live safe with other diseases, this is important. And I think we missed on that opportunity as well. We didn't do it.
Thank you. So Erin, moving to you, I'll let you come in with any insights you have, but I have a thought that maybe this COVID pandemic can be an opportunity, and maybe should be seized on as an opportunity. There'll never be another time where, the rich countries have the resources to fund some of these priorities. Their attention is focused. I think one lesson learned is that pandemics can happen. And the second lesson is that when they do happen, the losses to economic output and mortality are just almost incalculable or so large. So with that knowledge, I think there's going to be a willingness, once they get their own situations under control, to say, let's spend considerable resources just to sort of accelerate what needs to be accelerated to avoid this. And I think people are realizing with the variants that are circulating around the world and recirculating to rich countries and causing these outbreaks that it is a global public good. So do you see potential for leveraging this as an opportunity for the future?
Absolutely. And I think the economic loss has been enormous and is going to continue to grow. And I think that is an eye-opener to many countries to say, well, had we invested more, we wouldn't be in this situation right now. So you pay a bit more now, but the economic benefits you might not see for the next 20 years, 30 years until the next pandemic, but you will see them. And it's something that I think throughout history we need to acknowledge, is that we have pandemics that emerge every 50 years, every 100 years, whatever it is, we do have these pandemics, and they've been recorded and documented throughout history. And I think, we didn't have a really bad one since 1918. Yes, there were a few milder pandemics of influenza. 2009 actually ended up being probably a detriment to many governments investing in this space, because it was actually a rather mild pandemic. But I think it will make governments realise that they do have to invest in pandemic preparedness, and it will cost a little bit initially, or a lot initially, but the economic benefit when a pandemic hits again is going to be so huge. So I do hope that there'll be more investment in this area. Absolutely.
Thank you. So Tapiwa, it looks like you have to drop off because we're going late, but would you like to have some parting words before we lose your wisdom?
Thanks. I like the question on whether this pandemic is an opportunity. And I just wanted to say, as Village Reach, we work with community health workers. And what we have seen is that this pandemic has elevated the position of community health workers who have been undervalued in terms of their role in the public health space. A lot of planning for the work that community health workers do has mostly been done through small non-governmental organizations that are passionate about the cause of getting services to people in low-income communities. But we have seen that the governments have started to plan with at scale, accepting that community health workers can be a channel through which information can reach people, information about vaccines. They're a channel that can now, in contemporary times, be used to support vaccination efforts. They're trusted by the communities. So a lot of this vaccine hesitance that we're experiencing now is something that community health workers can really play a significant part in diluting. But when we talk community health workers, we are really talking about getting to the base of the pyramid. And so the extent, the logistic capacity that has to be developed, the volume of commodities that would need to keep them safe, the vaccines that would be needed at a particular time to have them vaccinating, say, even 3 people per day, would help, help us achieve that mass vaccination initiative that you were previously mentioning. Yes, it can be achieved, but it will not be achieved as long as we think services will and ought to be provided for through only the health facilities in the traditional way we have known them. So we're not inventing capacity. The capacity is there in the communities. It has been applied in previous outbreaks. It has been used in this COVID pandemic. It can be used for future influenza pandemics. And so, yes, there is a tremendous opportunity in the extent of resources that are available to government and how we can exploit those resources if we really want to be impactful in all communities without, being affected by whether there is enough money or little money. Community health workers would not cost as much as the trained health workers would cost. And so it's sustainable and it's efficient. Thank you.
Thank you so much. Really appreciate your insights. So we're coming to the point where we can start taking questions. Some have come in and some really specific questions about expiration dates of things, which are making me dizzy. Put your questions in the bottom, but while we wait for those, I'm going to throw out a hard question to either speaker, and you can pitch it. But this is certainly above my pay grade. But I think about it. Which agencies should take the leadership in this? I mean, if we simply say, somebody should be doing this, and there should be money supplied, is the World Health Organization or UNICEF, are they the right agencies to take leadership? Is it Gavi? Is it the G20, the G7? Do you have any thoughts, since you're kind of working on the the practical side of these things? And just throw it to either one of you.
So I think it needs to be multi-agency, but not too many cooks in the kitchen that you can't get anything done. But I think you need to have various agencies involved, and each of those agencies should have a specific focus. I mean, WHO obviously can't do it alone. UNICEF is the global supplier of vaccines to most children in the world. What WHO does have is a member states and ministries of health, and we can work with governments. Gavi has all of the experience in financing those Gavi-eligible countries to receive actually vaccine from UNICEF in their programs. And then there's other groups like CEPI that are really looking at potential pandemic pathogens, and they have their priority pathogen list, and they're really looking at these kind of cutting-edge technologies in order to have rapid vaccines produced in the event of a pandemic. So I think you need a little bit of everybody, and obviously you need the help of high-income countries to provide the lion's share of the funding that's required. I also think that low and middle income country governments need to contribute. I think all governments need to have skin in the game. There needs to be investment at every level. Otherwise, it doesn't work. So I think global cooperation is needed, but obviously you need to have some agencies that are taking the lead in certain areas. I don't know if Nagwa wants to add on to that.
I mean, would it be a crazy idea to say, look, we've been sort of taking hobbyist approach to this, and we got to take this seriously because this is the thing that can bring the world to its knees. This is the asteroid that's pointed at the globe, and we know that now. So the WHO is going to make this one of their big priority. It's going to take some serious funding, and we're going to increase the contribution amounts from all the contributing countries. And of course, you can bring in partners, SAPI on the R&D side and UNICEF on the distribution side. But I mean, is that a potential possibility? I think that there's going to be a willingness there for rich countries to say, yeah, it's going to be worth spending 0.001 of my GDP and an increased tax to help with this.
Yeah, and maybe this is something that will be proposed by the World Health Assembly from WHO member states. The World Health Assembly is starting next week. So it could be something. I think having done this for influenza, there was pandemic fatigue. So we started in 2006, just after, SARS and H5N1 emerged as a potential pandemic virus. And there were a lot of governments that contributed at the start. But the only government that stuck through to the end was the US government. And so that's something that I think a lot of governments end up is once you get a new government re-elected, what are they spending this money on? They could be spending it on, their own health systems or strengthening something in their country, traffic, roads, So I think that's the problem is the long-term political commitment, because I think what we might see in 5 years is pandemic fatigue, and everybody's forgotten about COVID. It's a routine virus maybe, and everybody gets their vaccine on an annual or biannual basis, and it just becomes another influenza. That's what my concern is. So I think there needs to be massive global cooperation and agreements that are signed and that are binding.
Yeah. I mean, I think saying, is this a potential, should we see this as an opportunity? I think one thing is that if you make investments not during a pandemic where the supply chains are so tight and, you can't get anything on anyway, they can go a long way to, small investments can produce really big returns if it's done in advance of a pandemic. And, the hope is that, even if it's not every country in the world, that you just take a small investment by some high income countries can push this forward pretty far. So now, what do you see? What's your thought on who should take the leadership? And I guess you would also agree it's a multi-agent.
Yeah, definitely, absolutely. And I think very interesting to go through the independent panel report, where there is a specific recommendation about addressing how can we look into future pathogens that can cause outbreak, because we don't want to see the same pandemic levels that we are. We should not be in that situation. This is the bottom line, is that if we are prepared, we would be in a different situation. But no one can prepare the whole globe. The whole globe, there is a multi-sectorial and each one work within mandate, but we have to work together. Low middle income have a stake in the game, as well as high income countries. And I think there is also the role for the Global Fund, for the IMF, for the governance structure that say that this is what we need, and this is what the level of investment we need, and this is how we want to use it. Because it's not only about vaccine, it's about human resources, it's about capabilities, it's health system strengthening. If we have the best vaccine in the whole world, if we don't have a strong health system to deliver the vaccine and to monitor, we will not be able to use the vaccine. And this is the lesson learned. We've seen that with Ebola. We've seen that with the zoonotic disease. These diseases that transmit through different vectors and cause pandemic potential. The work is not done on a vaccine level, and the work is not done at an organization level. It's done at a global level, and it's done a little bit lot before. So I really echo the same point as Erin, and I think the IPPR report has a lot of suggestions for the way forward, and it will be presented on the World Health Assembly next week as well for the discussion, which will, I hope that some of these recommendations will be taken forward.
Thank you. So we're actually coming up to the end. We only have about 3 minutes left. So let me just then open it up and maybe starting with Erin, if you want to just provide parting thoughts.
So I think actually, if we're talking about vaccine preparedness for future influenza pandemics, I think we should say future pandemics, because I think keeping influenza in a siloed approach, which has been what has basically been done for decades, is not the right approach. We need to be thinking in a holistic view that there could be any kind of, and especially respiratory, which is, highly transmissible, but any emerging virus that is respiratory in origin primarily, but perhaps other pathogens as well, that we need to be thinking about rapid platform technologies that can be leveraged very early on in a pandemic to get vaccine ready to be tested and then distributed to countries as quickly as possible. And in the same time, you need to be building that infrastructure in countries, these pandemic preparedness plans, to have distribution systems in place, address vaccine hesitancy, address the cold chain issues, address the issues of delivering to outside of the routine childhood immunisation schedule. All of those things need to happen at the same time in order to ensure that we're more prepared that next time we get hit by an unexpected virus or other pathogen.
That's really, really useful, because actually this is a big question where I'm on this panel to think about, what should happen for flu. And the question is, do you want to expand your remit? And it seems like the emerging consensus is you really want to take a more holistic approach.
Yeah, and even for surveillance, we've had SARI surveillance, which is built for influenza to detect influenza viruses as they mutate for both seasonal and zoonotic. And I think that system has been able to be leveraged for COVID, which is great. But I think having other surveillance systems in place, or expanding that SARI surveillance so that it can detect other respiratory pathogens that may not have exactly the same case. What's the word? The same symptoms. Yeah.
Yeah. That I'll take that to the committee too. Seems like we have hobbyist incentives as far as hoping people in their backyards are doing this surveillance, and we need to be much more investment, much more systematic, and it needs to be subsidized, I think. So Nagwa, what about your parting thoughts for the audience?
I think where I am seeing a big gap is the health system, so supporting essential service and health system. And I think vaccine is not it's a great solution, but it's not the first solution. And it adds up to the tools that we have to address pandemic. And my take is that low and middle income countries are suffering from the lack of essential health services that are manifested and multiplied when a pandemic happens. And I wish that we support the pandemic from that perspective, that vaccines for routine use, vaccine for the use of the countries will definitely impact on the long run on the vaccine of pandemic. And I think there is a lot of local initiative like this. African CDC is doing a lot of work around that and involving the continent population in clinical trial, looking to Africa more than opportunistic rather than really bringing their hand up to be part of the vaccine developers, more or less. Overall.
Well, thank you very much to all the speakers. As I said, I hope our audience learned a lot. I got a lot of wisdom to take back to the panel that I'm working on. So thank you so much.